There are three types of macronutrients plus ethanol. Carbs are absorbed as monomers. Remember acarbose, the alpha-glucosidase inhibitor, that prevents absorption of carb by preventing splitting of complex carbs into the monomer form, which is absorbable. Carbohydrates provide 4 kilocalories of energy per gram. 4 kilocalories of energy per gram. Carbs are going to produce 1 liter of carbon dioxide for every liter of oxygen consumed in their metabolism. So sometimes in patients who have hypercapnia, excess CO2 in their blood because of COPD, will reduce the amount of carbohydrate in their diet. Carb ingestion also increases blood glucose. It's a substrate that patients with diabetes mellitus must watch. Insoluble carb, however, is fiber. It's not absorbed. It doesn't provide calories. Protein is absorbed as amino acids. It provides 4 kilocalories of energy per gram, and it produces 0.81 liters of carbon dioxide for every liter of oxygen used in its metabolism. So carbs and proteins, both 4 kilocalories per gram. Fats are absorbed as glycerol and free fatty acids. Fat is a pretty good source of calories, 9 kilocalories of energy per gram of fat. For each 2 liters of oxygen consumed, fat is going to produce 0.71 liters of CO2. And then there's ethanol. Ethanol has no nutritive value. It does, however, provide energy, 7 kilocalories per gram, and it's going to produce 0.65 liters of CO2 for every liter of oxygen used in its metabolism. Alpha-glucosidases and acarbose. Remember that the alpha-glucosidases cleave polysaccharide into absorbable monosaccharide units. Acarbose inhibits these enzymes to limit glucose absorption. Notice that glucose and sodium are absorbed in a 1 to 2 molar ratio. In severe diarrhea, fluid replacements orally have this ratio of sodium and glucose. Carbohydrates are the type of macronutrient that have the greatest impact on blood glucose, so patients with diabetes often perform carbohydrate counting. An American Diabetes Association carbohydrate exchange diet considers 15 grams of carb as a serving of carb. Not all carbs are created equally because not all carbohydrates are absorbed into the body. We have two types of carbohydrate that aren't absorbed that we have to count for when we do carb counting. The first is fiber, the second is sugar alcohols. Within the category of fiber, we have two types of fiber. We have soluble fiber like pectin. It's going to lower blood cholesterol. It's going to delay and blunt postprandial glucose peaks, and then we have the insoluble fiber, the roughage. So anytime a serving of food has more than 5 grams of fiber, we're going to subtract all the grams of fiber from the total carbohydrate content when we do carb counting. In the label example in the middle, first thing we have to do is check our serving size. In this case, it's 1 cup. And then we see that the total amount of carb grams per serving is 31 grams in this example. In this example, it has 0 grams of fiber, so we don't have to worry about it. Another example, if we had 1 gram of cooked oatmeal with 25 grams of carb, and 6 grams of those carbs are dietary fiber, the total available carb is going to be 19 grams. 25 grams minus 6 grams. Which is really roughly 1 carbohydrate serving. Then we have sugar alcohols like sorbitol that aren't completely absorbed. We're going to estimate about half sugar alcohols will be absorbed to impact blood glucose. When we look at the label at the far right, we see we have 29 total grams of carb with 18 grams of sugar alcohol. So that means we're going to have 11 grams of totally absorbable carbohydrate. We're going to absorb about half of that 18 grams of sugar alcohol, or about 9 grams. So the total amount of absorbable carbohydrate to impact blood glucose in this example is the 11 grams of absorbable carb plus 9 grams of sugar alcohol to total 20 grams total absorbable carb. Let's do some practice. We have a patient with type 1 diabetes who uses a half a unit of insulin aspart for every gram of absorbable carb consumed. If they have 1 serving from this container, how many units of insulin should they inject? The correct answer is 13.5 units. We have 34 grams of total carbohydrate in each serving. We're going to subtract the 7 grams of dietary fiber to equal 27 grams of absorbable carb. If we're using a half of a unit of insulin per every gram, 0.5 times 27 is 13.5 units. Dietary fiber can reduce the absorption of carbohydrate from the diet, and it can increase satiety to promote weight loss. Additionally, soluble fiber acts as a prebiotic to support a healthy gut flora. Soluble fiber tends to delay gastric emptying, while insoluble fiber or roughage tends to increase peristalsis and decrease GI transit time. Both can reduce postprandial glucose peak, which can have a significant impact on hemoglobin A1C. We can see in this graphic the 2 types of fiber: insoluble fiber that includes cellulose, hemicelluloses, and lignans, and the water-soluble or dispersible fibers that includes the pectic substances, gums, and mucilages. While small amounts of free amino acids can be absorbed paracellularly, most are absorbed through facilitated transport both across the apical and basolateral membranes. There are 9 essential amino acids that can't be synthesized by the human body: methionine, histidine, tryptophan, valine, isoleucine, lysine, threonine, leucine, phenylalanine. My mnemonic is have true value in learning these little proteins. Additionally, 5 amino acids are considered conditionally essential. They can't be synthesized by neonates or by those with severe liver disease: tyrosine, cysteine, proline, arginine, and glutamate. Considering that tyrosine is a precursor for catecholamines and thyroid hormone, I'd say it's pretty essential. Most amino acids are preferentially metabolized by the liver. Branched-chain amino acids, leucine, isoleucine, and valine, can be metabolized by muscle cells. Hence, there's a theoretic advantage of supplementing branched-chain amino acids for those with hepatic encephalopathy or hepatic disease. A recent Cochrane review concluded that branched-chain amino acids help reduce signs and symptoms of hepatic encephalopathy without impact on survival. Similar recent studies have demonstrated reductions in morbidity and mortality when branched-chain amino acids are supplemented. Vegan diets can occasionally or rarely lead to essential amino acid deficiency unless care is taken to combine foods so that all essential amino acids are available. Wheat, rice, corn, and other grains provide limited amounts of lysine, threonine, and tryptophan, while legumes are low in methionine. We also have essential fatty acids. Linoleic and linolenic acid can't be synthesized by the human body. Omega-6 simply means that the first double bond in the molecule is 6 carbons from the omega, non-carboxylic acid end, while omega-3 the bond is 3 carbons in. Clinical signs of essential fatty acid deficiency include a dry scaly rash, decreased growth, increased susceptibility to infection, and poor wound healing. Omega-3, omega-6, and omega-9 fatty acids compete for the same desaturase enzymes. The desaturase enzymes show preference for the different series of fatty acids in the following order: higher affinity for omega-3, then omega-6, then omega-9. Consequently, synthesis of the omega-9 fatty acid icosapentaenoic acid increases only when dietary intakes of omega-3 and omega-6 fatty acids is very low. Therefore, mead acid, an omega-9, is one marker of essential fatty acid deficiency. A plasma icosapentaenoic acid to arachidonic acid ratio greater than 0.2 is considered indicative of essential fatty acid deficiency. In patients who were given parenteral nutrition containing fat-free mixtures, biochemical signs of essential fatty acid deficiency developed in as little as a week. Essential fatty acid deficiency has also been found to occur in patients with chronic fat malabsorption and in patients with cystic fibrosis. The 2 illustrations provided above show how both omega-6 and omega-3 precursors give active mediators in the arachidonic acid cascade. It's of note that the 4-series leukotrienes are much more inflammatory than is the cystinyl leukotriene LTB5. Likewise, the 3-series prostaglandins have diminished inflammatory potency compared to the 2-series. The more intense responses for omega-6 mediator actions increase the propensity for cascade overreactions that shift conditions from normal physiology to pathophysiology when the omega-6 precursor is the dominant fatty acid available. As a result, arranging for omega-3 fatty acid to be a greater proportion of the fatty acid can moderate cascade-mediated events and widen the therapeutic window for dietary omega-6 precursors. Of course, the cascade isn't the only way that fatty acid-based events can affect human health. Endocannabinoids, including arachidonyl glycerol and arachidonyl ethanolamide, are fatty acid-based bioactive lipids that act through selective receptors. The internet is rife with claims that the omega-3 to omega-6 ratio is critical. Little evidence exists to support an exact number. Suffice it to say that increased omega-3 fatty acid intake, especially combined with reduced omega-6 fatty acid intake, can produce health benefits. Abnormalities of lipid digestion do occur, and here are some common ones. First, pancreatic insufficiency, things like chronic pancreatitis or cystic fibrosis. Alterations in the acidity of the duodenal content, like Zollinger-Ellison syndrome, may cause abnormalities of digestion. If there's a deficiency of bile salts, like an ileal resection, bacterial overgrowth can lead to deconjugation of the bile salts. We can see decreased intestinal cell presence for absorption of lipids. We may see failure of synthesis of apolipoproteins, such as an A-beta-lipoproteinemia. And, most importantly, for your short-term goals, orlistat, the pancreatic lipase inhibitor, may cause abnormalities of lipid digestion. Fat malabsorption oxalate. Important enough to talk about twice. I wonder what that means. This diagram illustrates the origins of oxalate in enteric hyperoxaluria. In A, we see that the oxalate arises from glyoxylate metabolism in the liver. The remainder of systemic oxalate comes from ingestion of certain fruits and vegetables. The oxalate in these plants is in the form of relatively insoluble calcium oxalate crystals, so under normal conditions only about 5 to 10% of ingested oxalate is absorbed, and the remainder just passes into the stool. In patients with fat malabsorption of any cause, which is the definition of enteric hyperoxaluria, undigested fatty acids reach the large intestine where they can combine with calcium. As in B, the net effect is to release more free oxalate into the intestinal lumen. It's thought that this free oxalate is largely absorbed paracellularly in the large intestine. Due to the fat malabsorption among patients with enteric hyperoxaluria, the net percentage of ingested oxalate that ends up being absorbed can increase to up to 30%. Any oxalate that comes from the liver or is absorbed from the diet is delivered as seen in C by the blood to the kidneys D, where it's excreted through a combination of glomerular filtration and proximal tubular secretion. The increased delivery of oxalate to the kidneys leads to increased urinary oxalate excretion as seen in E, which in turn places these patients at risk of calcium oxalate kidney stones, corticomedullary nephrocalcinosis, and oxalate nephropathy. Parenteral nutrition, sometimes called total parenteral nutrition or TPN, is used to feed patients intravenously when they can't eat for protracted periods of time. TPN contains carbohydrate, amino acids, fats, electrolytes, minerals, and vitamins. The lipid content makes it look like milk. Compared to feeding through the GI tract, it's a fairly risky endeavor. Also, using the GI tract helps maintain GI function, so the bottom line, it's better to use the gut any and every time it's possible to do so. In chronic malnutrition, sudden reintroduction of calories can lead to significant shifts in fluid and electrolytes, particularly phosphorus, potassium, and magnesium. These shifts can be fatal, causing metabolic abnormalities, cardiac arrhythmia, and heart failure, respiratory failure, and or neurologic damage. To prevent refeeding syndrome, we initiate nutritional intervention by all routes slowly with gradual upward titration. One of the horrors of the Holocaust for the rescuers of the victims was not allowing these starving folks to eat freely, but rather restricting the calories to prevent refeeding syndrome. In severely malnourished patients, for example those with anorexia nervosa, we prevent refeeding syndrome by starting low and going slow. We initiate refeeding with less than 50% of goal calories. We aggressively replace electrolytes before increasing provision of macronutrients. Again, this applies to solid food, enteral feedings, and parenteral nutrition.